Hello, continuing with decoding the complex trauma. In this video, I'll explain to you how can we differentiate borderline personality disorder and complex trauma or complex PTSD. This is important not just for assessment, but also for planning the interventions and managing the risk using the trauma-informed care approach. My name is Gunjan Y Trivedi. So I have talked at length about differentiating complex PTSD from PTSD, and that's not what I plan to cover in this video. There are several videos, including case studies, highlighting those. However, in ICD-11 or International Classification for Disease version 11, there is a construct on separating borderline personality disorder from CPTSD as well as from PTSD. And therefore, I want to focus on that purely from assessment point of view so that we can identify what are the watch-outs and how to address them. When you assess, you understand what are the contributors or behavioral issues, and when you understand them, it's much easier to deal with them in the therapeutic intervention. So the idea is intervention, not just diagnosis. Let me be clear on also diagnosis versus assessment. Diagnosis puts a label. That's not the idea here. Assessment gives you an indicative directions of what are the common issues people face and therefore what you need to address. Okay. With this framework, let's go into what is the scientific evidence on helping us differentiate between BPD and CPTSD. This is getting more delicate when we know that risk factor, that is prolonged exposure to trauma, is common in both BPD and CPTSD. So we're not dealing with something that is obvious and simple. And when it's not easy to describe, measuring that is more difficult and addressing it is even more difficult. You will see scientific references so that you can delve deeper into what I'm talking about. And with respect to those references, there are several points that help us differentiate. First, assessing and understanding the exposure to trauma is not required in borderline personality disorder. However, assessing and understanding trauma is required in both PTSD and CPTSD. This is one of the simplest form to differentiate BPD from the CPTSD. For the second point, I'm going to just read through it so that I'm consistent in what I'm capturing it. Specific symptoms of BPD, which are not usually seen in complex PTSD, are strong sense of abandonment. Second, unstable sense of self, usually persistent over time. And finally, impulsiveness driven increased risk of self-harm and suicide behavior is a differentiator that isolates BPD from CPTSD. All these three conditions are present in BPD. Third point. Now, focusing on CPTSD, what separates CPTSD from BPD is the extreme negative concept of self. Here, the aggression or impulsiveness is usually less, and the relationships are more avoidant. So not an aggression in the relationship, which is common in BPD, but in CPTSD, a very strong negative self-concept, poor self-esteem, and avoiding social contact relationships. So therefore, relationships are affected in both. And finally, in BPD, that negative self-concept keeps creating issues with respect to goal, the belief about self, aggression, relationship issues. However, in CPTSD, that negative self-concept is extremely dominant and persistent over time. Okay, so these are the four concepts that have been talked in the literature with respect to separating or distinguishing BPD from CPTSD. Now, this is theoretical part and that's over. Now, let's look at the numbers so that we can validate what the theoretical constructs talk about. We looked at several data sets, more than few hundred individuals, personal interview and assessments. And this is what we discovered. So I'm sharing it in a form of an overview. First, the questions with respect to abandonment, the history of self-harm or the aggression, and the impulsiveness were very clearly on a stronger side in BPD. So the scores on this was yes or very high compared to CPTSD. So you'll see individuals who have a very strong impulsiveness, anger outburst, as well as abandonment feeling and likelihood of attempting self-harm, suicide or a history are likely to have tendencies or assessments related to BPD. This is something we saw in our questions. I will not share the details because the data is not yet published. This is first point that we discovered. On the second point, we identified 2 questions out of the ITQ, International Trauma Assessment on CPTSD, which refers to negative self-concept, questions C3 and C4 that you see on the screen. The average score or response for different individuals, starting with healthy controls, only post-traumatic stress disorders, borderline personality disorder, and complex trauma or CPTSD, is shown on the visual that you see now. And you can see the trend very clearly. In other words, CPTSD can be distinguished just on the basis of these 2 questions. Note, this is extreme sense of negative self-concept, hallmark of CPTSD assessment. And finally, you can see now on the screen the depression scores also progressively increase, starting with healthy controls, where we have a very healthy level of depression, which is usually below 19 on our major depression inventory assessment. And from there, we go to PTSD only, BPD only, and CPTSD only. And you can see that the depression scores usually increase. So this is also what we have noticed. So note that depression is common across these situations. However, the level of depression varies. So 2 things we saw: the concept of self and the depression level are both clearly high on CPTSD. Whereas in case of BPD, we would see the sense of abandonment, the impulsiveness, the higher likelihood of self-harm and suicide behavior are dominant. Finally, the idea, as I started to explain earlier, is to assess, to identify what are the traits or what are the behavioral issues which are present in an individual when you work with that person. By understanding them, we have made several meaningful conclusions and actions for addressing the problem. First, the risk of self-harm and suicide behavior, while it is present in CPTSD, is much less compared to BPD. So watch out for this. And to further validate this, we use ASQ, Ask Suicide Questionnaire, so that we are very clear on understanding and managing the risk, which involves seeking a perspective from psychiatrists before we pursue therapeutic intervention. So we are very clear on how this assessment is useful, especially to understand the risk the client has. And based on the risk, the trauma-informed care approach needs to be modified and very carefully incorporated in the therapeutic intervention. And finally, the idea of negative self-concept is so dominant in CPTSD, and unfortunately that cannot be addressed till we identify the PTSD component in CPTSD. So that becomes a very important understanding for the therapists in dealing with this person with this kind of background. And we also need to educate the person in the right manner while leveraging the trauma-informed care approach. So together, there are several implications of this assessment that we do, BPD versus CPTSD. And let me repeat this part. Identify the presence of BPD versus CPTSD is very critical for constructing the intervention for therapy. And specifically, the aggression or the impulsiveness, the likelihood of anger, the feeling of abandonment, and trust issues make the BPD very unique assessment and needs to be incorporated in a therapy. So I hope together that with the evidence as well as the data that I shared about what we do, you are able to understand the unique differences between the 2 assessments in ICD-11, and I hope it will help you design a therapeutic intervention. If you have any suggestions, I would like to hear about them in the comments.